Hello, and welcome to the Medical College of Wisconsin's Coffee Conversations with Scientists. I'm your host, Raina Andrews. And for those of you tuning in for the first time, let me introduce myself. I'm a mother, a children's book author, a public health ambassador, a TEDx speaker, and an engaged community member. Since 2021, we have been sharing the science behind today's most important health topics. Coffee Conversations is brought to you by the Advancing a Healthier Wisconsin Endowment, which is a statewide nonprofit working to improve health and advance health equity in Wisconsin. So, welcome to our virtual coffee break. You know, when you think about cancer, brain tumors are truly rare, right? But their impact is surely profound. With a 5-year relative survival rate of just 33%, brain cancer remains one of the most challenging diseases to treat. So today we're joined with Dr. Jennifer Connelly, who's a neuro-oncologist at Froedtert Cancer Center and a professor at the Medical College of Wisconsin. So I want you to grab your favorite mug and settle in for a thought-provoking conversation as we explore the science behind brain cancer, the stories of resilience, and the strength of a community fighting back. So welcome, Dr. Connelly.
Thank you, Raina. It is my pleasure to be here, and good afternoon to everyone who is out there.
Awesome. So we have a lot to cover in a very short coffee break. So be sure to get your favorite mug and to put your questions in the chat as we will get to as many questions as we possibly can. So let's get into it. We know a lot about a lot of different cancers, but I think even as we were promoting the show, Dr. Connelly, there were a lot of questions about brain cancer is rare and people saying, I know one person or I know three people. So let's really level the playing field and start with the basics. What exactly is a brain tumor and how do brain cancers differ from other types of cancers?
Yeah, so to get started, when we think about brain tumors, there's two main categories. There are those brain tumors that start in the brain, and we call those primary brain tumors. And then you have this other group of brain tumors that are from cancers that are throughout the body. So cancers like lung cancer, breast cancer, that then spread to the brain. And those are what we call brain metastases.
Hmm. So, brain metastases. So, when I was researching this, I heard of something called a glioblastoma. So, what exactly are glioblastomas and how does it differ from other types of brain tumors?
Glioblastomas are the most common primary malignant brain tumor. So it starts in the brain. It is an aggressive cancer. I have a picture I can share with you that can help show a little bit of the difference between glioblastoma and brain metastases. So the image that's on the left is an MRI, and you can see that there's a large, we call it heterogeneously enhancing. So it just means it has all this little spotty enhancement, but it's a single mass. And so that is a very common example of a glioblastoma. When you compare it to the image that's on the right, this is from a patient that has brain metastases. So you can see that there's three individual tumors that are throughout the brain. And so, this is, again, from a patient who probably had like lung cancer or breast cancer. So two kind of very distinct entities for sure.
Wow. I mean, looking at this is a very powerful image. I think we can take this down, but in looking at the one large mass and looking at the three smaller masses and thinking how sensitive and how important of an organ the brain is, I'm wondering statistically, as we look at brain cancer having a 5-year survival rate of just 33%, and of course that varies by the degree of the cancer in your body and your brain, what makes it so difficult to treat compared to other cancers?
So there's a couple of things when we think about treating brain tumors that pose some significant challenges. One of the biggest challenges is surgery. So how much of the tumor we can take out through surgery depends on the location. If that tumor is involving a critical part of the brain, we can't just go in and take it out because we would change who our patients are. We would impact their performance status and their quality of life. So the brain is a different organ compared to lung. We can take out someone's entire lung and they can still function fairly normally. So surgery is one challenge. The second challenge is the drugs. The brain is like this very protected space for a good reason. We get exposed to different toxins and infectious bugs every single day, and our brain is a tightly sealed space. But that same mechanism that provides us benefit, every single day also prevents drugs from getting in. So we have to really look at drug discovery and how we can get these drugs past the blood-brain barrier to really, start to treat the cancer in that form.
That's really helpful to understand those distinctions between the sensitivity of the brain and other things like breast cancer. As a woman, I think about do my own self exams at home. So I'm wondering from a symptomatic perspective, like if I feel a lump, I let my doctor know. But with brain cancer or having a tumor on your brain, what are some of the symptoms that might lead someone to seek care or let their doctor know?
When patients present with brain tumors, there's three main categories of symptoms that we think about. The first symptom, about one-third of patients actually present with a new onset seizure. And so usually that's a big change for someone, and they typically present to the emergency room. About another third of patients will present with headaches. Now, headaches are common. Nearly every single one of us have had a headache at some point in our life. But headaches related to brain tumors are a little bit different. Typically, it's a headache unlike someone's ever experienced. It is a headache that doesn't get better with rest, hydration, over-the-counter medications. And especially if that headache is accompanied by some neurologic symptoms, such as numbness or weakness on one side of the body, difficulty speaking, then that's a concerning headache to us. And then about one-third of patients will present with neurologic symptoms. So like the ones I was just talking about, numbness or weakness on one side of the body, visual changes where, someone suddenly can't see off to one side of the world, difficulties with speech, difficulties with balance. And typically these symptoms are gradual in onset and progressive. But these are also some of the very common symptoms that we see with stroke. So again, the brain symptoms aren't unique to brain tumors, but it tells us that there's something's going on with your brain.
Mhm. And so when I think about brain cancer and I think about all the information I know about cancer, I think this is probably the one that I know the least. Like I've heard of colorectal and I have a good sense of lung cancer. I know I have a good sense of brain cancer, of breast cancer. So I'm wondering, what do we currently really know about the causes of brain tumors? And like some of the other cancers, is there a genetic or hereditary factor that increases one's risk?
Yeah, so we really don't know the cause of brain cancers. There's a very small set of patients who maybe had radiation exposure during childhood for treating another type of cancer that can go on to develop a primary brain tumor. But the vast majority of brain tumors, there's no known cause. And it's been studied fairly extensively, looking at different environmental causes. There's a lot of research that went into cell phones. I think that's one of the most common questions I was asked years ago. And there's been no associated link. And so, no known cause. They tend not to run in families. About, less than 5% of glioblastomas are hereditary. So, much research to be done. I certainly have seen, small cases where there's been, two people in one family, but that's extremely rare.
Well, I'm glad you said that that there isn't a link between your cell phone and you carrying your phone like this, although you really shouldn't for a number of reasons have your cell phone up to your face. But it's good to know that the science really doesn't support that direct linkage in causation. So I'm wondering about treatment. You mentioned surgery and the sensitivity in conducting surgery around the brain. I'm wondering what are the treatment options available for brain cancer patients? I know with other cancers there's chemo. Is that an option for brain cancer?
Yeah, so essentially, nearly all of our patients will undergo surgery, first of all, to confirm what the diagnosis is. That's really important because it helps guide what our treatment options are, but also to alleviate symptoms. By doing surgery, you can remove the pressure that gets exerted on the brain and help patients feel better. When we're talking about glioblastoma, the treatment is really intense. Patients will then proceed with a combination of radiation and chemotherapy. Fortunately, the chemotherapy comes in a pill format, so patients are able to take it at home. But that radiation course is 6 weeks long, and I often, just tell patients and their families, this is a marathon. But you shouldn't be thinking about that last mile that you're running, just like you have to take every single, day at a time. Once they're done with radiation and chemotherapy, they get a 1 month break, and then they'll go on for like a maintenance period. And that includes oral chemotherapy. And then we often will talk about a medical device called tumor treatment fields or TT fields. And that delivers electric fields that helps interrupt with that cell growth and division. And that treatment, can be anywhere from 6 months to a year or even beyond.
Hmm. I'm wondering how this has evolved over the past decade, because when you talk about oral chemotherapy, and I think about from my limited experience and exposure with chemotherapy from some family members who have had to have it, what are some of the side effects? Will you lose your hair, or are these things that what can people anticipate with this type of intervention?
Yeah, fortunately, the oral chemotherapy is patients will often say is the easier part of treatment. The drug that we use is temozolomide, and it does not cause hair loss. The main side effect that we see is nausea, but we do a lot of education in clinic. I have a great team behind me that will sit down with patients and families and instruct them exactly how to take their nausea pill, when to take their chemotherapy. And when patients take it as instructed, it's really rare for us to develop intractable nausea and vomiting. And then the other main side effect is blood count issues. So while the chemotherapy is fighting the tumor and the cancer, it also can affect your blood counts. But we also monitor those with regular blood lab work, weekly. And fortunately, the vast
You've had
majority of patients
a
don't
very
require a
long, I want to learn more
transfusion.
about. Mhm. Speaking of transfusion and treatment, you've had a very long history with the Medical College of Wisconsin. I'd like to know more about your research at Froedtert Cancer Center and what you're finding.
So I'm fortunate to work with some fantastic research teams and have been involved with numerous projects. One of the most exciting projects recently is actually studying a new treatment for glioblastoma. And the name of the drug is gallium maltolate. And this is a drug that we didn't create it here, but we did the initial research here in glioblastoma. And so we really have taken this drug from like bench to bedside and recently completed a phase 1 clinical trial where it shows promise in terms that patients tolerate the drug well. But we definitely need to do some additional research with a phase 2 trial to start to look at, is this going to be something that changes the landscape of glioblastoma?
Oh, that's powerful. And so, with this treatment, I'm wondering what role does early detection play in improving outcomes? And are there any promising developments that you've seen in this area?
Yeah, I think certainly if we discover tumors early, before they have significant neurologic impact, if we're able to intervene with surgery before patients have significant disabilities, patients do better in the long run. Uh, Radiation and chemotherapy, we're very good at maintaining where patients' performance status is. But once symptoms develop, because that tumor can interfere with those pathways, it weaves in and out of that normal brain architecture. Sometimes it's hard to reverse those symptoms.
Mhm. So there are a lot of there's a lot of activity going on here in the chat. I don't know if you can see it if you have two pathways here, but I want to get this one question and we're going to turn it over to the audience if that's okay with you. Can I just ask one more question before we turn it over, Dr. Connelly?
Yeah, absolutely.
So I'm curious, like I've said this entire show that I would say brain cancer is probably the cancer I know the least about. And typically when something is happening, I go to Dr. Google. So I'd love to hear from you, and seeing that you've intersected with a lot of people on this topic, what are some of the biggest misconceptions people have about brain cancer?
So I think Dr. Google can often give bad advice. I often say the internet is often is outdated, and the statistics and numbers that are out there are based on old studies. There's new data that is coming out all the time. I think when people think about glioblastoma, they think about, time is short and that, quality of life is going to be impacted. And, they start to look at some of those median statistics, those median survivals. And I think we need to keep in mind those numbers. When you look at median survivals, half of the people pass away before that number, but half of the people live beyond that number. And I always want my patients to be on the other side of the bell curve. And my patients will hear me say, I want you to be the exception to the rule. So I try not to get too hung up on the statistics because no one is a statistic. I don't have 100 of one patient to say what's going to happen. And so we have to keep in mind those statistics are big groups of people and they have all different sorts of histories. And there's a lot that goes into how well someone can do with this tumor.
I'm so glad you said that because plenty of times people go online and say, "Oh, there's only a 3-year life expectancy rate," and start planning for their funeral in the end. And as you said, it's really acute care. It's a case by case basis, and everyone's different. So I really appreciate that perspective, Dr. Conley. So I'm going to turn it over to our audience. The first question that we have is one of our audience members is saying that his father had a glioblastoma. They're wondering, are they at high risk? And we addressed this hereditary piece earlier.
Yeah, so in general, glioblastoma tends not to run in families. When I meet patients, though, I do look at the overall family history, and if there is a history of having even other types of cancer, so not necessarily brain cancer, but at a younger age, there can be some hereditary syndromes that fold in other types of cancers as well as glioblastoma. So probably best just to review your family history with your primary care physician. If they are suspecting possible genetic link, then typically we have patients meet with genetic counselors who can talk about what testing might look like.
Mhm. That's really helpful. The next question is how is it that a person can have 3 different locations of tumors and they all be glioblastomas? Is that considered metastatic?
Yeah.
Metastatic? How come the first one wasn't found before the others developed? How does
Yeah,
that
so
work?
that's a great question. So when we see multiple spots in the brain, like before we've actually diagnosed the patient, we are suspicious for brain metastases. But there are cases of glioblastoma that can be in multiple places. We actually call it multifocal. And one thing we have to keep in mind is what we see on the MRI is not the extent of disease. We know from our postmortem brain bank that when we go like 2 centimeters away from an abnormal spot on the MRI, and so the MRI looks normal, but when we look under the microscope, there's glioblastoma cells there. So even though it may look like 2 or 3 distinct spots, they probably are connected at a microscopic level. This tumor, again, it has those tentacles people often talk about. It weaves in and out of that normal brain. And it also that adds to some of the struggles and challenges with treating this disease.
This next question dovetails really nicely with that. They're asking, why do the MRI scans show no change, but the patient exhibits signs that they are deteriorating and then pass within months? You may have already answered this. Yeah.
Yeah, no, and that is a very common question that I receive in clinic. And we see that. So we see patients who go through this intense treatment, MRI stable, but the patient just sort of slows down. I kind of call it the dwindles. They just, start to have less energy and maybe they have a little bit more confusion. And I think there's probably 2 factors. One is that there's this cumulative effect of treatment, which makes sense. Treatment has side effects. It's not easy. Each cycle of chemotherapy, each round of radiation, patients often have additional fatigue. But the other thing gets back to this, the MRI doesn't show us everything. So sometimes when I see the decline that patients are having, I do worry that maybe there's something happening at a microscopic level that we just can't appreciate. And they're absolutely right. Sometimes it's not till, 2 or 4 months later that we actually see the changes on MRI. And we think back and we go, well, the disease was probably changing at that time.
Got it. Before Dr. Conley, we talked about symptoms and risks. This next audience member is asking, is age a factor in brain tumors? Do the chances of developing a brain tumor increase as one ages?
Like most cancers, as we get older, we are at higher risk of cancers and malignancies, and brain tumors are no different. What we see with brain tumors is the older a patient is, the more likely it is to be a higher grade or a glioblastoma. So age does correlate. And then age also correlates a little bit with how patients do. And I think it just is as people get older, sometimes they don't tolerate the treatment as well.
Mhm. And so, for someone who wants to be proactive about their brain health, what steps can patients or families take to understand their personal risk factors and catch maybe potential issues early?
Yeah. So, because brain tumors tend to be sporadic, meaning they just happen with no known cause, there's no role for, having an MRI scan yearly to try to detect it. I think the best thing that people can do in general is if you are noticing changes in how your brain is thinking, or your body is working, really talk to your primary care doctor. Brain tumors are rare diseases, but there's lots of other neurologic illnesses that can manifest in the brain. And so it's important to have that evaluated by, the physician who knows you best.
Mhm. Now, this last question is totally beyond my head, but they're asking, do you have any comments on the FDA release of ONC 201? What is that?
ONC 201. So
ONC.
uh,
Okay.
that is a new FDA approved treatment within the past couple of weeks for a type of tumor that has been mostly studied, is a type of glioma. It's H3K27 mutated. It's a diffuse midline glioma, so it tends to occur in the middle structures of the brain. Um, these tumors are slightly different than glioblastoma. They're in a similar family, though. So I'm excited to have a treatment because this tumor that tends to be in the middle part of the brain is usually surgically inaccessible. And because the middle part of the brain is, I call it the highway, it's like everything converges down and then goes out to control your body. Patients who have tumors there can just be impacted significantly with symptoms. So to have a new treatment, we are always excited about new treatments, and we've been actually waiting for this one for years.
So, I mean, the way that you just described, I said ONC, you're like, onk. Like, oh, oh, thank you for helping us better understand that. And
Yeah.
one of the last questions does talk about treatment. They're asking, why does the treatment cause damage and then need surgery from the radiation? How can you tell the difference on scans?
Yeah. So every treatment we do has potential side effects. The dosing of our treatment is based on what most people tolerate well. But some people are a little bit more sensitive. Some tumors are a little bit more sensitive to radiation. And therefore, in the process, while the tumor cells are dying, it irritates that surrounding brain. We actually call that radiation necrosis. And it's a good thing because the treatment's working. It's just sometimes we need to go in and do surgery to sort of clean it up. Our body has its own way of kind of cleaning up dead cells and dead debris, but sometimes it just can't keep up fast enough. And that's when we talk about surgery or sometimes some medication interventions.
So, what I'm taking away from this, Dr. Conley, is that there's no one size fits all solution to address someone who is identified as having a brain tumor. I'm also understanding that brain tumors do not discriminate by age, by ethnicity, by hereditary disposition. So, this has been very informative to me, and you are truly an expert because as a layperson, I have a much better sense of what brain tumors are and what glioblastomas are and how things can metastasize in the brain and what that means. So I appreciate this. And so with that, I'm wondering how does the community, people like myself, play a role in supporting brain cancer patients, and what more can be done to really raise awareness and fund some of this research so we can begin to have greater advancements like some of these other more familiar cancers?
I think it's really important when we have these rare diseases that we do raise community awareness. And I'm fortunate over the years that I've been practicing to have families and patients who have really contributed to those efforts. So one organization is called Chasing Chad, and Chad was a patient of mine, and his family has done amazing work with raising community awareness. They have events throughout the year, and they actually have an event coming up. They have a yearly casino night that I frequently attend, and they bring in speakers. Chasing Chat is great. They've been supporting a lot of our research here at MCW, but they also support patient needs, which we've talked about how devastating this disease is to patients and families. There's another organization, Strain for the Brain, that one of my patients started 16 years ago. And this hosts a yearly run walk that I've been participating in from nearly the beginning. And it's been amazing to see how this rare disease, initially was a couple hundred people. And this past June, we had over 2,000 people there. And to see that community and the support of the patients wear they're called our warriors. They wear yellow shirts. So you look out amongst the sea of 2,000 people, and you can see people who have been through the same thing. And to see their friends and families rally gives me goosebumps every year. And I know I shared with you a link to a video that I think really captured that day, and well beyond the words that I can put it in.
This is so inspiring to hear about the advocacy and people power. It really warms my heart to hear, even over the years, how your patients have really turned their experience to really be warriors and champions for the cause. So we're putting in the link in the chat right now, links to Chasing Chad, Strain for the Brain, and a video, an inspiring video of the most recent run walk. And so if you're a listener out there and you're wondering, how can I get involved? It's like, I know someone who has passed from brain cancer. I know someone who currently has brain cancer. I think these are wonderful ideas that Dr. Connelly has just shared about how you can lean in and demonstrate advocacy, help raise funds, and really support this research. So with that, I want to thank you, Dr. Connelly, for joining us today. We appreciate you taking the time to join us for a coffee break and really explore this important topic.
Well, thank you so much, Raina, for having me. It's been a pleasure being here, and have a great afternoon.
Thank you. And for all of you out there in the interwebs, if you did not get to your topic, your questions, or if you have topic ideas, please email me at conversations@mcw.edu. I hope you all enjoyed our coffee break. We look forward to seeing you next month for another coffee break with a scientist. Have a great week.